Welcome to Building Another Entity Other than Medicare webinar. This webinar is designed to help you determine when you should bill Medicare or if there's something that should happen before or after. Now, what we've done is looked at data to drive this webinar and your questions. For me today, I'm Tom Ryan, and I'll be your presenter. I'm with Provider Outreach and Education. I'm joined by Mary Muko from my team, and she's going to do our technical stuff. If you have any issues going on, you can throw that into chat. However, again, I do recommend emailing us. Also, she's going to help monitor and answer questions that are in the chat. Now, those questions will be posed to me depending on the time at the end. So please make sure you put questions into your chat. What are we going to do today? Well, we're going to start with a little bit more housekeeping. And this housekeeping is some basic things. First, we were asked about the presentation, and the presentation is available on our training center. You can go ahead and download that right now if you'd like. The training center is available on our website. You can go right to the top and get the material. Now, the training center does have a live events page where this presentation would be available right now. Once it removes from the live events page, which will either be later today or tomorrow morning, you'll have to wait until we upload the encore. Then the presentation will be available in the encore presentation page for 60 to 90 days, but it's still available. We want to make sure it's there. Please check out our upcoming education and our on education. Again, with this, please put any questions that you have in chat as you have them. This is the best way for us to get the questions in. We want to make sure we can answer them as you go. Last, you'll be given the opportunity to provide feedback. Now, the opportunity will come via a survey. The survey link will be posted in the chat multiple times, so you don't need to say the whole thing. You can still give me survey feedback. Tell CMS how we did, please. We just want to know. If you give us anything less than the perfect 5-star rating or 5-point rating, please indicate what you didn't like or what we could have done better. It only helps us to improve with what we need. So what do I have to talk about before we get into the topic? Well, first, this material is a tool to assist the provider community. Again, one of the things we did with this was to look at the Medicare rules, regulations, how they change, what we can do. So we wanted to make sure we kept it current, which we did. 2, we also wanted to make sure that as a tool to assist you, we gave you the answers and the data that's current. So we looked at what was going on, the questions you were asking, and that's where the material came from. With that said, of course, the answers are based on the information that I was given during questions or that I was able to get from previous webinars during questions. So that's what we use to determine all of it. Remember, the Medicare regulations will always be ruled, will always be the final coverage determination, and these are accessible on the CMS website. Also, if you are recording this, I do ask that you stop recording. There's no screenshots, recording, or anything like that. What we do is record it. We encore. We'll put it out on our YouTube video as an encore. So please make sure that you are aware of that. Few people asked again, what are we doing today? Now, this was in the advertisement. We want to just go back over this. The goal is to help you determine when to bill other entities, okay? Not traditional Medicare Part A and B. Now, this could be anything from a primary insurance to Medicare Advantage plans, hospitals, etc. We really want to look at that. That's why we're talking about the different parts of Medicare and the different items that go with it. We also would like to provide you with some resources to help you. Now, again, I did the best I could with the questions that you gave, but some of the questions you gave were very vague and not specific enough for me to answer. So if you say to me, I didn't answer that question, you need to send it in again via that email that I gave you. That will give you 7 days after this event to get that answer. Please, I had 4 questions that were claim specific. We have this claim, here's the number. I cannot help you with those. CMS requires those to be tracked and those to go to customer service. So if you were one of the 4 people that chose to give me a claim specific question with internal control number during the registration process, I will not be answering them today. They're not applicable across the board to everyone. So I want everyone to be aware of that. Let's start with our first kind of what should we bill? First, of course, Medicare secondary payer or MSP. So I want to remind you, Medicare secondary payer, just as an overall, is when there is someone else that is responsible for considering the claim before Medicare. One of the first questions we got is, does it have to be an insurance? And the answer is no. Let me give you an example. If a person falls at a store, that store does not have liability insurance. If it is that store's fault, such as they had a wet floor, they didn't clean the snow, the store is considered self-insured, and in that case, the primary payer is the store itself. So it does not have to be an insurance in order to meet the Medicare secondary payer MSP guidelines. Okay? So what you're looking for is, when do we need to bill out to this other insurance or to this other payer, and what happens? And we'll talk more about these different situations. Now, again, this is going to be a big area where we're going to get into some of those questions. All right. First thing you have to know is that there are different types of primary payers. And the first one is employer group health plans. Now, this is something that is divided into three different areas, and people don't necessarily understand this part of it. A group health plan, which is someone that is age 65 and older for Medicare. So Medicare eligibility, 65 and older. They then have an employer group health plan. It's called a group health plan. This one has an active criteria of 20 or more employees on the plan. And you're like, hold on, how do I get that information? You don't always have to have that information. What you can do is use the eligibility systems to determine whether or not that plan is primary. And if you don't know, you can call the BCRC, or Benefit Coordination and Recovery Center. If you type BCRC into the CMS website, you'll get their contact information. Keep in mind, you are not asking if the patient has another insurance. You're asking if the insurance that you know about is primary or not. It's two different questions, okay? Along with a group health plan, there is a large group health plan. Now, there's a distinct difference, and the difference comes from the person's Medicare eligibility. So while the group health plan was 65 and older for Medicare, the large group health plan is not. It is under 65 and Medicare eligible due to a disability. Now, the reason it's called a large group health plan is because it has to have 100 or more active employees. So when you look at the age of your Medicare patient, this will directly affect that coverage. How does it affect it? If there are 100 or more employees, that group health plan, that large group health plan, is primary. Same thing, if there's 20 or more and they're 65 and older, then the group health plan is primary. So you can see there's a bit of a difference there. And the last category that goes with that employer group health plan is for someone who has end-stage renal disease. Now, end-stage renal disease is different. It is not based on the number of employees. Instead, when this provision was written into the Social Security Act, it's based on a coordination period. So this is 30 months. During the first 30 months, Medicare is secondary and other insurance is primary. Once that time frame passes, then the other insurance becomes secondary and Medicare is primary. Nothing to do with the number of plans. Also, one of the questions that we received during this time is it only related to something for end-stage renal disease? And the answer is no. Once you have employer group health plan primary, they cover for everything not related to a specific diagnosis. The next part of that question was, there are non-employer group health plans, and how do we classify those, or how does Medicare classify those, I guess would be a better way of saying it. These ones are all related to incidents, illnesses, injuries, something like that. And the first one you can see here is the workers' compensation. This is an accident, illness, or injury that happened on the job. Each state sets what a workers' compensation claim will be within their state, so they can vary slightly and differently. The next category is called federal black lung, and this is under the Department of Labor, the federal U.S. Department of Labor. And so they determine diagnoses that must be billed to the federal black lung program before billing to Medicare. These are all in the Internet Only Manual. There's also liability insurance and no-fault insurance. Now, again, these are state-based, based on what your state establishes as liability versus no-fault, but are also incident-related. So you have to have something going on to make this work. Someone did ask me, and I did want to take just a moment to show you where you can get more information. First, these types of insurance are very complex. So what we've done has actually taught classes on this. So I'm going to go ahead and come out to the WPS GHA YouTube channel, Government Health Administrators Education. This is our YouTube channel. Take a minute and go to the playlist. When you go to the playlist, you are searching for a playlist, and I'm just going to use the word secondary. It will bring up the Medicare secondary payer playlist. Now you can see we have a variety of different items down here, but the nice thing about the playlist is it's going to bring them all up in one location, and you can see them all listed here. Okay. Inside this particular playlist, if you open up some of these titles, you will find one called Employer Group Health Plan and Non-Employer Group Health Plan. They are down here. They will go through all of the caveats I just went through, except in a lot more detail. So if you need more information on that, please feel free to ask. We do want to get that information for you, but I need you to put it back into chat. All right, so let's talk a little bit more about these different items. Group health plans are, again, always determined by the person having Medicare. Remember, their age is a determining factor. Are they 65? Are they disabled? Or do they have end-stage renal disease? And depending on their Medicare eligibility, then determines the type of group health plan they have. So if you don't know this information, and that's that how are they eligible for Medicare, then you do have to get back in and check the systems and make sure. One thing I do want to tell you, and someone did ask a question on this, when does someone become eligible for Medicare? Is it their actual birthday? And the answer is no. Medicare eligibility occurs on the first of the month in which you turn 65. So it's not necessarily your actual birthday. It could also be if your birthday is the first of the month prior. So that makes sense to you. So if your birthday is January 1st, it'll be December 1st. If your birthday is January 2nd, it's going to be January 1st, the first of the month prior. They also ask what is normal for disability eligibility, and it's 24 months after receiving Social Security disability income. Okay, so this one's a little different in that you do typically have a time frame to wait. The reason we use the word typically is because there are certain types of disabilities, ALS being an example, that would not make you wait that time frame. You automatically start with SSDI and you automatically start with Medicare. So, all right, so determine your group health plan type. That is key because when you bill, if you don't have it, you will not be able to get us the correct type of information. So you must say, okay, it's an active employment. Is it age related? Is it disability related or end stage renal disease related? That's your group health plan type. That does have to come in on the claim. If you do not code that correctly, it will not come in correctly. Now, I will tell you, in most cases, not a big issue. We don't see a lot of these being miscoded in terms of that way, but it does happen on occasion. So, all right, someone asked about COBRA and why do we put that on there? Most cases, we say it's an active employment plan. COBRA is the exception, and COBRA is written into the section of the Social Security Act about end-stage renal disease. So if a patient is not eligible under end-stage renal disease, COBRA does not apply. It is not considered active insurance. On the other hand, if they're Medicare eligible due to end-stage renal disease, then COBRA does apply, and it follows the same primary coordination period. So there's been a little bit of confusion about COBRA and when it applies and when it doesn't. So hopefully I just answered that question. All right. So what's our current issue? Well, one, keeping the records up to date. How many guys have had this problem? Oh, well, yeah, we know they don't have, or what so we know whatever the situation is that this particular record is not updated. It needs to be updated. First, we as a claims processor cannot update it. We cannot help you do that. That is something that you can do by getting information from the primary insurance and getting it up to date. You can bill the primary insurance, right? That's fine. If you do that and they deny it, then bill us with that denial, and that'll make us process it as primary. You could also contact the patient to have them update their record. You could have the patient appoint you as a representative, and then that would go through for a one-time thing. You could call while they're in your office. Again, that's a one-time thing. Now, if they did a full form appointing you as a representative, that would be a little bit different. So we ourselves are not eligible to update this. We can't do anything with this. However, we do know that the records need to be updated. One of the issues we currently have is people keep submitting every so many days, 30 days, 60 days, and the records are not current. They didn't update the records haven't changed. We find this more commonly with billing companies or third-party people. And what's happening is they're not doing anything, and we can't do anything other than call it a duplicate claim and say, still can't process it. So please make sure that you're making all of those options and attempts before that. The next issue that comes up with primary payers, and we hear this a lot, is that they don't decide a claim timely. And so if they don't decide the claim timely, what do you do? Well, first, know the Medicare filing deadline, and that is 1 year from the date of service. Here's what I want you to keep in mind when we talk about this. 1, for outpatient services, it is 1 year from the date of service. 2, for inpatient services, it's 1 year from the date of discharge. You still have to file your claim within that time frame, regardless of whether or not they've made a decision, regardless of whether or not they've paid. If the claim isn't filed timely, Medicare will not look at it. Medicare will not reconsider it. Medicare will not work with it even after you get a decision. So I want to make that as clear as possible. You know it's not. You don't have it. You don't have the decision. You don't have what they're going to allow. You don't have any of that. Still file it. Let it deny. We can work with a denied claim. Okay. Now, if you happen to miss it on a timely filing basis, yes, you can go out and you can ask for a timely filing exception. Not a problem. We understand that this happens. However, CMS does not grant timely filing exceptions based on the fact that the primary insurance did something, and that can even mean they came back and took their money back. This is not something we can help with, not something we can do. If you disagree with that, take it to CMS, take it to the regional office. Right now, the timely filing exceptions are very limited. I did ask Mary to put an article in there for timely filing exceptions. That'll get you the guidelines, but it's also going to get you to the IOM and to the Code of Federal Regulations and all those areas you need to look at, okay? So when an insurance comes back and takes their money back, we also know that some people are saying that's not a timely decision. We understand that. You filed it or you didn't file it because they paid it in full. Here's the thing, always file your claim to Medicare. Even if you're filing it just because, which some people say, well, why would I want to do that? There's no patient liability, there's nothing going on. If they take it back and we've got it, we can work with it. If they take their payment back. If we don't have it in the system, we can't work with it. And it's not going to be something where we can come back and say, this is okay, because no, Medicare says it's not a timely filing issue. You should have filed it that way. One other question that I did receive is, are we required to fill a claim when the patient has unmet deductible, even if that patient has no liability? And the answer is yes, you are. Medicare deductibles can be met without the patient paying them by filing a claim when they have primary insurance. This is part of the way in which Medicare helps and uses that primary insurance to save the trust fund money. Okay, so please make sure you do file those always. One other thing someone did ask about is conditional payments. Again, on that playlist that I gave you earlier, there's a whole class on conditional payments. It's an hour long, so I don't want to get into all the details of conditional payments. Here's what I do want to let you know. Yes, you can ask for conditional payment. Please make sure that if you're billing on the UB04 or the 837I, that you do put the appropriate indicator under the claim to ask for it. If you're billing on the 1500 or the 837P, put it into the system, let it process, and let it deny. Then you can ask for a conditional payment. It's a couple of different processes there, and it just depends on how you bill. So what is a conditional payment? It's a payment issued by Medicare to give you funds while we wait for a primary insurance to make a decision, so that the patient isn't liable, but also so that you are not sitting without the revenue. Here's the thing with a conditional payment. It is conditional upon the primary making a decision, and once that decision is made, you will work with Medicare to determine whether or not you owe money. A lot of times, though, with conditional payments, the primary will owe Medicare money, or someone else will owe Medicare money. To give you an example of this, In an auto liability, you filed for a conditional payment. We're going to give you the money. We're going to let you keep the money. We're not even going to ask you to return it. In some cases, the attorney will contact the coordination center. They'll work with them and they'll actually pay back from the lawsuit or from whatever's going on. So it's very conditional on that, but the condition is eventually Medicare does have to work with it. All right. Hopefully I got enough information on conditional payments and kind of working around that. So please put that back in if you do have questions on that. Missing primary payer information. Now this is one that we do not process. We either process it as, hey, nope, it's incomplete, which means it's going to return to provider if you are billing on a UB04 or an 87I, or it's going to be unprocessable if you're billing on an 837P or CMS 1500. Unprocessable, fix the claim, submit it again. If it's returned to provider, you enter the system and you must enter the claim again. Okay, which means fix it, correct it, do what you got to do. Basically, we don't have what we need. We can't fix a claim. We can't process this claim because we have it. We're missing something primary. Now, this is different than when you have the primary insurance listed. However, you don't have the payment amounts listed. That will cause a denial. And that's what we were talking about before when we said make sure they're filed timely, even if the primary hasn't made that determination. We're okay with that. So there's a difference in not having the information and having the information, but not having the payment information, not having the primary payer information versus the payer or the payment information. And they do act a little differently. Okay. So just make sure that you're aware of that. Of course, what's that bring us? The first set of questions. The first set of questions are going to be related to Medicare secondary payer. What I'd like to do is have you guys put some questions in chat. While you do that, I do want to answer a few of them that were received from the pre-submitted during the registration process, and then we'll take the live questions. So here we go. Coordination of benefits. I did talk a little bit about this. I think I'm not really sure where you were trying to go with it, but the coordination of benefits for Medicare does revolve around one, the type of insurance, the Medicare eligibility, and then also the payment differentials can be different. So I'm not really sure where you want. So if you want more on coordination of benefits, take a look at those YouTube videos out there. There's a lot of information out there. Okay, once you have a corrected EOB, what do? You can do a couple of different things, and it's going to depend on how you submitted your claim and what actually happened with the claim, if this makes sense. So the primary sends you the information. If you're an 837I biller or UB04 biller, you can actually go into the system and correct the original claim. If you are a CMS 1500 biller, you're going to submit it. Your claim will be denied. It's a brand new claim coming in because now you've got different information. Your claim will not duplicate against that brand new claim because it's got additional information. So I wasn't really sure which way you wanted that one handled, so I put it both ways. Again, if you have more questions, go ahead and throw that back into the chat. How do you know when the insurance is primary and secondary? Again, let's talk about this real briefly. We offer a variety of tools, and I'm going to show you our website because I want you to see some of these tools. When you look at our website, again, our website is wpsgha.com. Let me get back to the homepage here. One of the first primary tools that a lot of people use is this portal right here. It's a login section. You may hear called the CMA or the SecurityNet X portal, the portal. This also has an eligibility feature. And by going to the portal user manual, you can actually see this eligibility feature. But keep in mind, I can't enter the portal. I don't have a reason to. On the other hand, I can use the portal user manual to educate you how this is going to work. We're going to scroll down, and we're going to scroll down to My Transactions, and you're going to do an eligibility check. Once you enter your information for your eligibility check, look away if you don't like a fast scroll. So look away. If you do, just bear with me. I'm going to scroll down to it. I'm going to scroll down through, I can get my eligibility check, and then I'm going to scroll down until I come to this section called MSP, Medicare Secondary Payer. And there's a lot of information contained within this. A couple people have asked why I recommend using the Medicare Secondary Payer information on the portal versus like the interactive voice response, which we're going to talk about in a second. The portal contains all of the Medicare secondary payer listed along with their expiration dates. The IVR does not. It will give you some but not all of them. So I just recommend using the portal because it's going to have a more complete list. That's it. If your date is a little bit older, it will give you a more complete list. So I just really do encourage you to use our portal. All right. You also heard me mention the Interactive Response System, or IVR. That is the telephone system, and you can find a variety of features on that. If you're looking for IVR information, I always recommend just put it right here in the top in the search feature. Go to the operating guide. Here's a little background information. Here's the printable one. It's going to talk about it. Okay. If you don't want to go to the background and you'd rather go to the overview, we can do that as well. But again, I think it's easier. Just put it right there, search for it. It's going to pop right up. You're good. Talk all about the information you need. A couple people have asked us, do we have a tool to help with this? And I do want to point this one out too. The IVR conversion tool, which is right here, will say if you have text like a person's name that you need to enter and how do we convert that into a number, that's what this will do for you. So I do recommend take a look at those different tools. The last one is direct data entry. This is another tool. It's DDE, very commonly referred to. This is only for 837I or CMS 1450 UB04. So it's the FIS system, the Physical Intermediary Standard System, and it's a way they can access it. This does not apply to the other two types of claims. But all of these will give you that different pieces of information, and each one of these we do offer help for. So really take a look at this and get into that a little bit if you need to. Go from there. That'll bring us the first opportunity for Mary to ask me questions that you guys have posted in the chat. Mary, any questions?
Hi, Tom. We have gotten a few questions, and one of the questions concerns the updating of records by the BCRC. Do you want to talk a little bit about the beneficiary's responsibility for getting information into the BCRC, or perhaps how providers can help the patient do that?
Sure. So the BCRC is the Benefits Coordination and Recovery Center. Now you can go through and navigate to this on the CMS website. So I did go to cms.gov to start with. I don't really like to do that. I prefer just to type. Let's just look up the BCRC and go from there. Now again, Benefit Coordination and Recovery Center, or Mary, can you see the changes, or did my CMS website just freeze?
It looks like it froze, Tom.
Okay.
There
Okay,
you
well,
go.
there we
Moving
go. Okay,
again.
so it's a coordination of benefits and recovery overview right here. I do recommend take a look at this website. This is going to help you a little bit. The reason I recommend that is it's got all this information listed on it. I like the contact section for contacting the BCRC. Okay, this is where I'm going to go with this. Here's how you can call them, get them that information. Here's what you have to know. One, can a provider help the patient update these records? Yes, they can. Again, as I said, they could call with them in the office and be on the phone with them, in which case the patient can give them a one-time authorization. Now, if they're not in the office with them and they choose to party call them, conference call them, however you want to term that, a lot of people will do that too. That's okay. But again, it's only good for one time. Could a patient fill out an appointment of representative form and have a primary or have a provider work on their behalf? Yes, but it also is very limited, and there's a lot of information you need to know that goes into that. It's probably not going to be your best way. Could a provider themselves go to the BCRC and get information updated? And the answer is yes, but you must have the information on letterhead or official information from the primary insurance. So hopefully that makes sense. Yes, you can help the patient, but there's a variety of different factors that go into it. Again, if you need more, throw that back into chat. Mary, let's go on to the next question.
All right, Tom, I'm scrolling through here. There is a request. Could you expand more on the conditional payments on one of your slides? Does this apply to group plans or just liability and auto?
Okay, so conditional payments rarely applies to group plans. Now we say rarely because there's always an exception for Medicare. Here's the thing. It is going to apply to something like auto, liability, workers' comp. Any of those could definitely be something that fall into a conditional payment situation. I do recommend that if you're looking for more information, especially on conditional payments, stop and listen to the 1 hour class. Keep in mind, it's an hour long. I can't get you that much information that quickly. Also, I do recommend coming into the CMS website and taking a look around it. There's a lot of information on the coordination of benefits and all of these different things where you can find out about conditional payments. So if I were to give you the best piece of advice I can without going through the full class for it, come out here. Again, this is the YouTube playlist, the Medicare Secondary Payer playlist. Scroll down, and what you're looking for is a class. Wrap up. I just got to find it. Called Medicare Secondary Payer Conditional Payments. This class is being repeated later this year. If I had to guess, or I guess early next year, I'm not real sure, but we're going to do a live question. So to take a listen to this, it gives you the information. Phenomenal. Also, if you want more information, feel free to open it up. There are resources you can just go to find more about this. Okay, so this is what's great about this is we actually are going to give you the resources you'll need right here on YouTube as well. If you can't do that and you still have additional questions or concerns, please feel free to email me. I can get you this presentation. It's just that it's not available on our website anymore, but we'll get you the presentation. So drop that into that email that we gave you earlier. All right, Mary, anything else?
One last thing, Tom, and I did answer this question privately. It had to do with the timely filing of claims. Maybe you can pull open that resource on our website and show people exactly where we provide information regarding those denied claims not filed within the time limits due to third-party errors. I know that a lot of providers always ask, or often ask, where does it say this? So if you can go to the timely filing of claims.
All right, so the first thing I did is I'm not going to try to jump around and show you where it's at. I could go to Topic Center and say, hey, this is in claims. Now we're going to go here. We're not going to do that. We're going to put timely filing. That's the topic you're asking me about. So timely filing of claims. This is it right here. What I'm going to do, and this is the resource Mary's talking about. It actually explains when timely filing applies. It takes you out, tells you the chapters and sections and the information you need. So third-party error. Okay, so right here, we know that we're looking at this. Here's the quote: third-party payer in making a primary determination does not constitute. This is in, if you'll notice, it's in italics, it's in quotation marks. This is what CMS issues us. If you want this directly cited from CMS, take a link right here and you look for section 10.11 or 1011. You're going to come out here, you're going to open it up, and you're going to say, okay, well, now we have to come out and say good cause. A good cause section, and it's going to say notes. So again, we're just going to cite back to the CMS sources. I do recommend just hitting timely filing. It's going to be there. So that's where we get that information from. So this article is a great resource to start with. However, it's not the end all be all. You do get extra links and extra information within it, including that if you do have a timely filing situation, how you'll write to us and get that information to us. Okay. Please make sure you're using the Part A versus Part B sections. Part A will always be, doesn't matter what the service is, it's going to be anything billed on a UB 04 or 837I. Part B will be anything billed on a CMS 1500, 837P, can affect these addresses to the claims manager. J5 is Iowa, Kansas, Missouri, Nebraska, and our national contract. J8 is Indiana or Michigan. So make sure you're using the correct section once you search that article. Okay, Mary, any other questions?
We are all caught up, Tom.
Perfect. We're going to go ahead and go on to the next area. Now, this one is the parts of Medicare, because Medicare is a bigger process and it's got a lot of different components within it. So we really do want to focus on that. The first big thing that we got to ask with Medicare is Medicare Advantage plans, MA plans. So how does this all work together? I'll give you a little bit of an understanding with it. Can't go through the full process. Now, we do have full classes that talk about MA plans, okay? So again, you can listen to that if you're interested. So first, a Medicare Advantage plan is a patient's choice to replace traditional fee-for-service Medicare. Traditional fee-for-service Medicare is Part A and B. This is Medicare. This is not a supplemental or a different payer. You cannot bill Part C or a Medicare Advantage plan and then still bill Part A and B. We're going to deny. This is our number one denial. Did you catch that? For traditional fee-for-service Medicare in jurisdictions 5 and 8, this is our number one denial. So you have to, one, Check eligibility to verify. Does the patient have this type of a plan? If they do have this type of a plan, then you will bill that plan. If the patient says, I no longer have that plan, we again cannot update this system. This is actually done by the Medicare Advantage plan into a system that goes into the Social Security system. They then transfer it to us. So if that breaks down anywhere along that update way, we can't do anything about it. It's the Advantage plan's job to work with Social Security Administration to get that system corrected so that it does come to us. We will sit just like you will with denied claims because we can't do anything. Okay. Now, whose job is it to update that record? It is the patient's job. It is their plan. You can't update it for them. You can't say, hey, they don't have this anymore, right? But the plan also has responsibilities. And so therefore, there are things you can do like contacting the regional office that controls this plan if they're not doing their job, if they're not helping you, if they're making it harder for you. So let me show you a resource that may help you. It may not. It's up to you to use it if you want to. Okay. I'm going to put right here in this search feature, MA, Medicare Advantage, plan. And if you guys see me stop, I'm just waiting for it to catch back up as I'm typing directory. What this is going to go out is search, and it's going to bring up this Medicare Advantage plan directory. This plan is updated. What's awesome about it is it's going to list your plan. It's going to list which regional office controls that plan, who can help, because we cannot help you. If it's in the system, we can't do anything. Now, you've heard me say if it's in the system, but what systems do you check? Again, it's the IVR. It's that direct data entry system. But most importantly, it is our portal. There's a whole separate thing in that eligibility area that you can go to on our portal to find out about MA plans. Now, again, why do I recommend the portal? Why do you keep hearing me emphasize this section? Because when we look at this, this is going to get you more information than a lot of the other ones in that it's going to list all plans available. What you're looking for is MA. You can see it's the third item right here on my screen. If I scroll down, and I'm just going to scroll down to where you'll see that, so look away again. Here, you're going to see what it's going to provide. One of the questions I did receive is the portal is giving us wrong information. We don't know this plan. Here's the catch, that MA plan directory will list the legal business name of this plan, but it will also list the doing business as name. So it gave me the name and I went out and looked in the directory. It's actually what the portal is giving them is a legal name versus what they're knowing as a doing business as name. It's not a different plan at all. The patient doesn't have two of them. It's just how it's listed within the system. So please take advantage of that directory. Make sure everything matches and goes back and forth. If this information is not up to date, we cannot process this claim. Can't do it. So they are separate. They are separate from traditional fee-for-service Medicare. Keep in mind the word replacement. They replace Part A and B, okay? So it's a little bit different there. Next item that we get to talk about is what we like to refer to as bundling, and it's one of the forms of bundling. Once a patient becomes inpatient, okay, not outpatient, not under observation, inpatient, the hospital has the responsibility to bill all services during that time. That means that the outside provider will bill the hospital. Now, someone said, what would be an outside provider? Like, what are you talking about here? This could be something like an ambulance supplier taking someone for an MRI and returning them to the original facility. So you're taking them and returning them. That ambulance trip is not separately payable because they were inpatient. This could be something like the technical component of a lab or a diagnostic test. Okay. Not professional services. Remember, some of those professional services, They're outside that, so they still get billed to Part B, but they get billed in that 1500 claim form. They get billed on, for a critical access hospital, they could be a method 2 billing. So when we look at this, they're going to be billed separately, but you must still indicate correctly. So a lot of what happens with this one is, yes, it's still billed to Medicare, only it's not billed separately. It's billed through the hospital to Medicare on their claim and incorporated into their payment system. It's called the Inpatient Prospective Payment System, IPPS, for acute hospitals. For critical access hospital, they have a different one. There are some that are like psychiatric hospitals have their own. So it just depends on what you're talking about. But it is a form of bundling. And remember, once the patient's inpatient, this takes into effect. Okay? One of the questions we received is there a place on the system that will tell us this direct information? And the answer is we don't have an exact area on the system. Here's why. With a hospital, you do not file an admission right away. They actually will file the admission after that first month has passed. They have a time frame that they file within. They do monthly filing. So you can actually have filed something, gotten paid, and all of a sudden you get money taken back. It's still part of that hospital claim. It is part of the Medicare process. It's an automatic take back. We don't control it. The system does it. So when we see those, there's nothing we can do with that. The system will take that money back. Now you do owe it to Medicare, you pay us back, and then you have to bill the hospital for that. They can then adjust their claim. Now, if a hospital adjusts their claim, that can also stop their next claim from processing because each claim must process in a certain order and they are time framed. So you can see there's a lot of different moving parts that go into that. But we wanted to make sure that you're verifying the status. Ask your patient, hey, are you in a hospital? Hey, what's the situation going on? If you know the patient's in a hospital, let's say it's your lab, and you know they're coming from the hospital or the lab work came from the hospital and they're inpatient, but the system's not showing it, which means you checked into the Part A eligibility area and there's no hospital days remaining, or there are hospital days remaining. You want to make sure you wait for that system to update. Otherwise, we're going to pay it because it's not there. We don't know that yet. And then we're just going to take the money back later. So just a couple of key things with that one. Now, unlike hospital, there's also another type of bundling that people are familiar with, and this I like to call skilled nursing facility consolidated billing. I will tell you that right here on the slide, there's a link to the skilled nursing facility consolidated billing site. Take a look at that. Now, this one is different than hospital. Hospital bundling is basically for all things except for professional charges. That makes sense. Skilled nursing facility is not for all things. Skilled nursing facility consolidated billing says, yes, the skilled nursing facility must bill for what's within their scope of practice. Hold on, how do you know if it's within their scope of practice? And that's where you have to look at that consolidated billing list, and you have to have the procedure code. Each procedure code then can be done in certain areas, and if those areas are outside the scope of practice, you can bill. Now, we'll let you know, again, go back to that playlist. Instead of selecting the Medicare secondary payer one, look at for consolidated billing, the skilled nursing facility consolidated billing. This is much more complex. Those files are very, very much in play. The thing is not all patients that go into a skilled nursing facility will stay there the whole time. Sometimes they're granted day passes. They're allowed to leave for a period of time when they may come to an outside provider's office. It doesn't mean the skilled nursing facility is not responsible for those services. Just because they didn't know doesn't mean they're not responsible. So verify if they're medically necessary. Someone asked, like, what is a good question? So here's my question for you. Start with, are you staying somewhere else? Not you live somewhere else. Because they may not consider this skilled nursing facility their home. They didn't move, they don't live there, but they're staying there temporarily. They could also be staying at something like a person's house or their child's house or a friend's house or a relative's house. That would play into home health next, so we'll talk more about that. So we want to make sure that you're asking that question. Then sometimes you have to go back to the skilled nursing facility and be like, hey, is it medically necessary? Or is Medicare actually covering it? Because Medicare only has a certain number of days that will cover it for. And once we reach those number of days, we're not covering the stay anymore. Also, if it's not medically necessary, then it's no longer covered either, in which case you would bill. So What's going on? Is the skilled nursing facility putting them on a leave of absence, which means they won't be there for the midnight census on the day that you saw them? If that's the case, then they can't bill for that day, and that day would be billable to Medicare. But none of that can be done until all of those claims come in. So lots of questions with the skilled nursing facility other than just, hey, it's a skilled nursing facility. Okay. Next situation that comes up is home health. So the patient's under a home health plan of care. This is not considered a home service. Part B will cover home services. Home health actually involves a plan of care. This is where the patient elects to have that home health agency bill for their services. Once this election is done, there are certain services that must go through this. Let me give you an example. If you're doing something that a PT could do, even if the PT didn't do it, that is a therapy service, okay? Therefore, it is part of the home health services and should have been done by the home health, therefore it bundles in. Someone asked about wound debridement and about certain types of wound care. These are services that a PT can do. They are state qualified, they are qualified under that, and therefore it is expected that the home health would be billed for them, even if the patient comes to your office. So it's either going to be billed to the home health agency or we're not going to pay it. So you can write it off if you need to. So there are certain times when people say that too. So please make sure that you're aware of home health. Hospice is the next one. This one is unique, and a lot of you guys have probably heard of this. So it says it has to be related to the hospice diagnosis. So the patient first must elect hospice, then select a person to manage their hospice. This plays into the modifiers that are built. Once they've elected hospice, they must be at the hospice location for this to occur. Did everyone catch that? They have to be at that hospice location. The reason that I brought this up is we had an ambulance provider on the call who said, I'm not getting my ambulances claims paid, but it's before they've elected hospice. I'm sorry, after they've elected, but before they were admitted. It must be billed. This claim must be billed with a modifier GY indicating it's unrelated. The system cannot differentiate the time that the hospice started, and the hospice cannot start until the patient arrives at the hospice, which, by the way, had to be done through your ambulance company. So our workaround is to indicate to you to put a GY on it so that we know this is not under the hospice plan of care yet. Okay. So yes, we're looking a little bit more about that. So when you build a hospice, yes, you're going to want to bill them. Okay. Now, when you bill for a GW or a GV, GW or GV, the GV is the one that says it is a patient-elected physician who is not employed under the hospice. They're not paid under arrangement. They're not part of the hospice. So they can elect anyone they want to manage that, okay? That's what you want to use the GV for. I will tell you, one of the questions we had came in and said, can we append a GV onto any professional service? No, it's only for the attending physician. A GW, on the other hand, can be appended to anything that you want. For those of you that bill on the UB 04 or 837I, yes, you can use your condition codes. I don't want to make it seem like you can't do those. So you would use that, and that would be condition code 52. If they move out of the hospice area, you could use condition code 07. It's not related to hospice, or a D1. You're making an adjustment because of hospice, and then you want to explain that. So it just really depends on the situation that you have. All right, the next one is a little bit different, and this one is a demonstration project. So some people have asked us about these. So first, a demonstration product is something that CMS sets up. Sometimes they're specific to certain types. They're specific to certain types of situations or certain things. Some people have clinical trials, which will also be demonstration products. So it really, demonstrations are unique. I do recommend that you go to the CMS website and you research the demonstration product that you're asking about, because each one is unique. It has unique billing criteria. It has a variety of different things that you need to be aware of. Each demonstration project can be billed either by a Medicare administrative contractor, such as the ABMAC, It could be billed to one specific payer who's doing it for the entire nation. It could be billed to an MA plan, depending on the type of MA plan and depending on what's going on with that. So many different things that go into that. Demonstration products, which again do include that clinical trial elements, they are not your standard item, and there's so many different ways you can go with that one. It's very, very hard with that one for us to answer it. So again, go out, look up your specific demonstration product, look up your specific clinical trial, and determine, does an MA plan cover that clinical trial? Does it not? Do I have to bill to this MAC? Do I have to bill to this MAC? Who gets that bill? They're not going to be the same, and each one is unique. If you to offer a demonstration claim, we will not process it. We will either return it to you or make it unprocessable. We can't touch it. Okay, so all right, let's get into the next area of questions, which is the parts of Medicare questions. Oops, sorry, again, I must be having an issue with my mouse here. Okay, so how do you determine which part of Medicare to bill? And the best way I can tell you to do that is to look at the eligibility systems that I've already talked a little bit about, that I've shown you. Look at your eligibility, look at your claim status, look at your deductibles, check for any of those types of things. If a patient is running that, you want to make sure you're getting whatever information you can. Now, again, remember, some of those systems are going to be a little off. So for instance, if you look up home health and eligibility and you're like, oh, they don't have one, I'm good. Guess what happens with that? The patient then, the home health agency then files their home health election, and oops, now they suddenly have it. Well, we don't know that at the time, so we're going to process it based on what's happened, based on what was there at the time. That's where we get those auto takebacks, which we don't control. So the best way we can give you is to look at that. Again, we did have a couple of questions on those clinical trials, and I can't emphasize enough to say, check out the same thing with the demonstrations and the clinical trials. Each one is unique and different, whether an MA recognize them, whether a traditional Medicare recognizes them, who you have to bill for. It is a whole separate ballgame when we get to the clinical trials. With that said, Mary, I would like to ask if we have any questions in the chat.
We've received one question during this particular portion of your presentation, and the question is, with the home health debridement, and the CPT code is given there, home health providers are stating that they're not responsible for payment on a particular claim. Is there anything that providers can do to help the home health plan or home health providers know that they are indeed responsible for the claim payment or consideration?
Yeah, so here's the thing with home health that's unique to WPS as a Part A BMAC. We don't actually process home health claims, so I can't really answer a lot or give you a lot of resources on that. What I would say is research the CMS website for home health. I also recommend going out and looking at the home health MAC, Medicare Administrative Contractor website. It is going to be H&H, Home Health and Hospice MAC, and they have a lot of great resources. Now, again, we don't have those resources because we don't process those claims. It's not our provider. If ultimately you're really struggling, please feel free to reach out to your regional office, and depending on where you're located, it'll be the J5 regional or the J8 regional office. They may be able to help you as well. If they're not paying you, it does become a legal issue between you and them. So you can reach out, get the reasons you need, and then ultimately it winds up being back to a legal issue. Mary, do you have anything else that you'd like to offer on that one?
I don't, but as you were talking, Tom, I was looking for the review contractor directory. It's an interactive map available on the CMS website, and that map does identify the various contractors by state. If you're interested in contacting, your home health intermediary specifically, or your home health hospice MAC. Again, there we go. I'll put the URL into the chat while Tom is searching. And there it
Well, it
is.
looks like
Well,
it's opening. So you
yeah.
scroll down and you can see a variety of different things. I did not get the map.
And for whatever reason, Tom, I did notice this earlier this week when I was looking at it. Maybe CMS is making changes to that interactive map. Typically, when you go to this page that Tom is showing you, a map of the United States pops up and you just simply, click on your particular state. It has not been doing that. I'm assuming, Tom, that CMS is making updates to that interactive map, but it looks a little different than what is typically there, but I'd try back just in a few days and maybe they'll have that update made.
So if I was just going to search, here's how I did. I'm just throwing Nebraska in there. Here's Nebraska. If I scroll down through Nebraska, I can see the home health and hospice information available here too. It'll get you to their website. So even though the map's not there, just use the control find or edit find, however you want to do that. Bring your find feature up, throw your state in, boom, you're right there. So great opportunity. Let's move on. The next section is actually something we've already done a little bit of talking about. So I put it in here as just as a reminder so you can see what's available. I don't spend a lot of time on it because we've already talked about it. So the interactive voice response system, that's that telephone system. You already saw where the information's at on our website, but please keep in mind it is a touch tone and a voice response system. So if you find that it doesn't like your accent or it doesn't like how you're saying something, yes, you can use natural speech with this, but you can always use the touch tone. I showed you the conversion tool for that. The big one is the portal. This is our secure section, and I really do recommend this. I will tell you again, everyone needs to have a unique username and password to access this. It is a personal account. It is not a shared account. However, on this one, with the unique username and password, you must be approved for MPI information. So that just simply means, hey, this provider has someone that represents them. They have to approve it. All right. Direct data entry, we talked about this. It is again for the FIS system, and it is for UBO 4837Is, and you can do a variety of different things, but if you want to check that out, I do recommend looking at that overview. What's next? The CMS website. And I've been here a lot. I'm not going to go back out there again, but the CMS website is the official website. Want to remind you of that. We do offer guidance. They offer the official rules and regulations. So we gave you a variety of different items that you'll need with that. Hopefully that works for you. All right, so let's run through some questions that were pre-submitted real quick, and then we will be done for the day. So can you further explain a VA and when the VA and Medicare will both pay? The answer is, first, the VA is Veterans Administration. It's another federal benefit program. If the VA pays, Medicare will not pay. If the VA does not pay, then Medicare will consider for primary payment. So it's either the VA or Medicare. Yes, a patient can choose which one they want to use. There's no problem with that. A patient does have the right to choose that. So that's the VA for you. One will pay, not both. When you're trying, the next question is, can you explain a little bit about determining how the patient liability is figured when there's another payment? It's actually pretty simple. Look at the Medicare allowed amount. And did you receive up to or above the Medicare allowed amount? If you have, the patient has no liability. If you did not, then the patient owes you the remaining difference. What services require an ABN? This is a very complicated question because it's not really a service-driven item. It's a medical necessity-driven item. In about an hour from now, we're going to start a class all about the ABN. Come to that class. I'll teach you more versus trying to get into it here. Again, we just want to make sure that you have what you need. All right, I don't have time to check with any more questions, so we're just going to go ahead and move on. Proof of attendance. If you said, hey, I want to attend, but I want a certificate of attendance that I can show that I was there, we do offer that. It is going to come to you in an email. We do not offer a separate one. This will give you your contact hours. This is something you are able to save. This is something you are able to use to get CEUs if your governing body allows. You must ask your governing body. We don't do that. However, you can take the survey right here in the top. Mary's going to put a link back into that. So we're going to have a lot of different information available on that. But please save that email. Open it, look at it, and make sure you're saving it. If you have questions after today's event, I'm going to give you 7 days to send those in to me. That means noon, 7 days from now. Here's what I'd like you to do. Go ahead and put today's topic, which is billing another entity other than Medicare. And then it will come to me. I will get back to you in an email. Okay, I'll get back to you in an email. 7 days to give me those follow-up questions. Survey. You've heard me mention this a few different times. I'd really like your feedback. Tell me what you think I did good. Tell me what you think I did bad. Tell me the PowerPoint's good, bad, or ugly, whatever you think about all of those different items, it's my way to help myself improve. CMS does look at our survey results. They want to check it out. So tell us along with CMS so what we can make it better for you. The survey link is available in the chat right now. You're going to get it in the follow email, and we're going to want it so bad that I'm even going to give you, when I close out of this, you're going to get a website that's going to be an external pop-up. It's going to give you a little triangle. You can see me circling it right here on this slide. Going to have a link. Yes, we know this is going to look a little spammy or a little fishy. It's not at all. Go ahead and click continue. It'll take you directly to the survey, but please provide that. Again, if you're giving me anything less than a perfect, provide comments. Tell me what I did or what I can improve. If you give me a 2 or a 3 and I don't know what is wrong, what I can do to help you, then I didn't do my job, but I also don't know what you needed more. So help me understand. All right. Whoops, that brings us to the end of the class today. Remember to complete that survey. It's always good for us to have that. Take time to review those live events. Take time to get that PowerPoint if you want to. Also, remember to check out our encore presentations. On behalf of myself and Mary Muko, all of Provider Outreach Education, thanks for participating. We look forward to your comments and your surveys, and we hope that you'll join us in the future. You may now disconnect.